My name is Natasha Shirvill and I'm going to present on narcolepsy, especially how it is diagnosed and understood using neuroscience techniques. There are several symptoms of narcolepsy, most notably excessive daytime sleepiness, even after an adequate night's sleep. A person with narcolepsy will usually feel refreshed after a night's sleep or day nap, but sleepiness returns 1 or 2 hours later. A person with narcolepsy will often have trouble staying awake, concentrating and functioning during the day, and may fall asleep or become drowsy at inappropriate times and places, for example at school or work. They will usually experience disruptive nighttime sleep and disordered rapid eye movement sleep, which can occur at any time. Elements of REM sleep can also occur during wakefulness, creating an intermediate state between sleep and full consciousness. Some people with narcolepsy also experience cataplexy, which is characterized by sudden, emotionally triggered episodes of muscle weakness with preserved consciousness. These episodes may begin with weakness of the muscles in the face and followed by the limbs and trunk. Cataplexy can result in complete body collapse, speech may be slurred, and vision impaired. Cataplexy can cause anxiety and fear of situations or people that might elicit an attack. People with narcolepsy may also experience sleep paralysis, which is the temporary inability to talk or move when waking or falling asleep for up to 1 or 2 minutes. They may also experience hypnagogic hallucinations, which are vivid, sometimes disturbing dreamlike experiences that occur while dozing or falling asleep. Hypnopompic hallucinations are similar but occur when awakening. Hallucinations may be visual or auditory and last 1 or 2 minutes. People with narcolepsy may also experience autonomic behaviours, for example talking or putting things away during sleep with no memory of these actions when awakened. There is a wide variety in the development and severity of these symptoms, and not all people with narcolepsy experience them all. The Epworth Sleepiness Scale, which is an 8-item self-report questionnaire, is used for screening but not diagnosis of narcolepsy. For diagnosis, the overnight polysomnogram, PSG, followed by a multiple sleep latency test, MSLT, the next day is used. The PSG and MSLT measure brainwaves using EEG, as well as eye movements, skeletal muscle movements, and heart rhythm. The overnight PSG rules out alternative explanations for excessive daytime sleepiness, for example insufficient sleep or other sleep disorders, and identifies whether nocturnal sleep is light and fragmented, and the person falls asleep quickly into REM sleep and experiences less non-REM sleep than people without narcolepsy. An EEG recording during sleep is similar to when a person is awake. It is characterized by high frequency, low amplitude activity, as well as rapid eye movements and quickened breathing. A person with narcolepsy falls into REM sleep more quickly than other people and experiences less non-REM sleep than other people. The MSLT lasts a full day, and the patient is encouraged to fall asleep for 20 minutes every 2 hours. The MSLT uses EEG to measure sleep latency, that is how long it takes to fall asleep, and how quickly the person falls into REM sleep. The MSLT helps distinguish true daytime sleepiness from physical tiredness. In a separate test, low hypocretin 1 levels in the cerebral spinal fluid are highly specific for narcolepsy. However, this test requires a lumbar puncture and analysis of sample is not always readily available. The International Classification of Sleep Disorders is where the diagnostic criteria for narcolepsy is found. There are 2 types of narcolepsy. Type 1 narcolepsy is diagnosed when the person experiences daily periods of an irrepressible need to sleep or daytime lapses into sleep occurring for more than 3 months, and low hypocretin 1 levels in the cerebral spinal fluid or cataplexy, and a mean sleep latency time, that is the time it takes to fall asleep, of less than 8 minutes, and on 2 or more occasions on the MSLT falls into REM sleep within 15 minutes, that's a SOREMP, or 1 SOREMP on the MSLT and 1 on the preceding PSG. Type 2 narcolepsy is the same as type 1, except that cataplexy is absent and hypocretin 1 levels are in the normal range or have not been measured. The neuropathology of narcolepsy is not fully understood. However, as shown in this figure, a loss of hypocretin orexin-producing neurons is thought to be responsible for lowered motor cortical excitability and reduced activity in the histaminergic system in people with narcolepsy. The neurons that normally produce orexin help sustain wakefulness, and a loss of orexin-producing neurons leads to sleepiness and lapses in sleep. However, differences in orexin levels suggest that type 1 and type 2 narcolepsy may be phenotypically similar with different underlying causes. Sleepiness and other symptoms are generally more severe with type 1 narcolepsy, and the diagnosis is more straightforward. A number of other neuroscience tools have been used to provide more information about narcolepsy, although these are not presently diagnostic tools. For example, magnetic resonance imaging indicates that specific anatomical changes may differentiate narcolepsy patients from controls, as well as subgroups of narcolepsy patients. MRI indicates that the cortical thickness in prefrontal areas is inversely correlated with the severity of narcolepsy, and that there are clusters of cortical thinning in patients with child or adolescent narcolepsy, but not those with adult-onset narcolepsy. Further, transcranial magnetic stimulation, TMS, indicates that there is lower excitability of the excitatory circuits and enhanced excitability of the inhibitory circuits in the motor cortex of people with narcolepsy, and that modafinil, which is a wakefulness-promoting agent, has an effect on the cortical excitability in people with narcolepsy, possibly because it acts on the GABAergic inhibitory circuit. fMRI indicates a decreased volume of grey matter in patients with narcolepsy and cataplexy, especially in the hypothalamic region and thalamus. This is consistent with the loss of hypocretinergic neurons. EEG with low-resolution brain electromagnetic tomography provides evidence that people with narcolepsy have a functional deterioration of the frontal temporal parietal network of the right hemispheric vigilance system. Lastly, diffusion tensor imaging indicates that people with narcolepsy have widespread microstructural white matter changes, including in the hypothalamus, mesencephalon, pons, medulla oblongata, that are not visible with conventional MRI scans. These changes are in accordance with disturbances of the hypothalamic hypocretin system and its roles regulating REM sleep. For the time being, the diagnosis of narcolepsy is difficult and challenging, and the main tools are the PSG and the MSLT. However, this graph shows that narcolepsy usually begins between the ages of 10 and 25, but the diagnosis takes a long time, 5, 10 or more years. As the onset of symptoms past the ages of 40-45 is relatively rare, the age of the first onset of symptoms may be a factor to consider when deciding on a diagnosis. As to why narcolepsy is often misdiagnosed, there are many reasons. One is that poor sleep is common, especially amongst teenagers, parents, and shift workers, and sleep disturbances accompany most medical and psychiatric disorder. Further, excessive sleepiness is often misjudged as laziness, lack of motivation, or intellectual inadequacy. Narcolepsy can therefore be confused with many conditions, including just insufficient sleep, obstructive sleep apnea, delayed sleep phase disorder, periodic limb disorder, shift working disorder, and the use of sedating medications. It can also be confused with depression and hypoglycemia and hyperthyroidism, and in children, attention deficit hyperactive disorder, because sleepiness can cause behavioural issues. There are therefore a number of challenges to the diagnosis of narcolepsy, which is often misdiagnosed or not even considered as a diagnosis. Whilst the MSLT is an objective measure of excessive daytime sleepiness, it has low discriminative ability between excessive daytime sleepiness of narcolepsy and daytime sleepiness in other conditions, may be misleading because of the occurrences of false negative results. Type 1 narcolepsy is easier to diagnose than type 2, and low hypocretin 1 levels are highly specific for narcolepsy. Nevertheless, while a definite diagnosis may not always be possible, narcolepsy is very likely to be the correct diagnosis if a PSG indicates fragmented light sleep and early transition into REM sleep, less than 15 minutes after the onset of sleep, and the patient usually falls asleep in less than 8 minutes for a nap. Healthy people take more than 15 minutes, and has a REM sleep during at least 2 of the MSLT daytime naps. Where diagnosis is ambiguous, a second MSLT may be used to confirm the diagnosis. Thank you for listening to my presentation today. These are my references.